Hello everyone, I am Dr. Kshitiz Raj Pokhrel and I'll be discussing about the radiology part in the CE exams. The radiology it carries about 7 marks in the exams, but it can be in a form of integrated from other fields as well, like obs gynae, surgery and orthopedics. So it's very important to know the details about the radiology, and it's also one of the most sought out branches. So it's very important in the CE exams, and I'll be discussing today about the musculoskeletal system and the basic introduction about the basic imaging modality. So the topics I'll be discussing about are the brief introduction, the anatomy of the bones, periosteal reaction, briefly about the general diseases related to orthopedics, usually the osteomyelitis, metabolic bone disease, common fractures and dislocation, and tumors. There are various imaging modalities. We mainly talk about X-rays, which is the plain film radiography, the CT scan, MRI, and other radionuclide imaging, even nuclear imaging also there. But we'll be just discussing about the basic things: the X-ray, USG, CT, and MRI. So the plain radiography is a first order diagnostic imaging modality in every these procedures related to radiology, and these X-rays are just electromagnetic radiation which are similar to the visible light but of shorter wavelength. So here you can see the X-ray. There is an X-ray tube which has an anode and a cathode, and the X-rays are emitted from the cathode towards the anode, and X-rays are emitted, and there are primary radiations going towards the patient, and there are even scattered radiations that are emanating from the patient, as well as there is anti-scatter grid, and the last is the image receptor, where there is further interaction can occur. We will not be discussing about all these interactions in this session. So the basic introduction in the X-ray are these are given as shades of gray in the film, and based on the various densities of the anatomic tissues that the X-ray pass through, these are referred to as the radio density. And if the materials that inhibit the passage of the radiation, then they are more radio dense, and those that allow the radiation to pass through them easily are referred to as the radiolucent materials. So as I have already told, the air, fluid and fat, they are generally towards the radiolucent spectrum, and the air becoming the most radiolucent one, which is in the form of black, and the bone or other contrast medium and even solid metal are towards the radio dense spectrum, which are which appear as white in the X-ray films. So here in the image we can see the clavicle, the humerus, the scapula. The bony part appear as whitish, whereas the air in the lungs appear as black. And even in the image below, the X-ray of the ankle, we can see the implant is shown in as white, because it's more denser than the bone. So these modalities I have already talked about: the X-rays, USG, the CT, which stands for computed tomography, MRI, magnetic resonance imaging, and nuclear imaging. Even other scans are there, right, like radionuclide imaging, which we'll not be discussing today. So here you can see the X-ray in which the bones are shown as white. The tendons, the muscles, they are relatively radiolucent than the bones. And this is the same thing of the X-ray lateral view of the pelvis of the lumbar spine, lumbosacral spine, and these are the reconstructed 3D images. This is the anterior, posterior, and the 3D reconstructed images, which is the CT reconstructed images. These are MRI images, which are more good for delineating the soft tissues, the joints, as well as the surrounding structures, the ligaments, tendons, etc. Now we'll be talking about the anatomy of the bones. So basically the bone is comprised of the epiphyseal end, which is shown in the epiphysis containing which is contained in the either ends of the long bone. The metaphyseal ends, which is just below the between the epiphysis and the next one we'll be talking, the long shaft of the bone, is the diaphyseal end of the bone, and between these metaphysis and the epiphyseal end is the physis end, which is the growth plate, or the actively the part which which actively grows. So on the in the X-rays, usually the facial end is because it's a cartilaginous end and it has to ossify for further growth, maturation. So these usually these are shown as lucent, or these appear as black. These regions appear as black in the in the immature bones, and with ongoing mineralization and calcification, these appear become more dense, which will then become whiter. So this is a schematic, this is a diagrammatic representation of the bone, in which the bone is comprised of the central, the medullary cavity in the center, and then the cancellous bone with trabeculae, and apart the outer part will be the compact bone, and then the outermost covering, or the outermost covering will be the periosteal layer, which has an inner and outer layer, and even the compact bone has various like osteons. It's made of osteons, which are the proteaginous component of the bone, and which are semi-cylindrical units connected to each other by these canals that we can see in them, and these are connected through canals, and between the two canals are the Volkmann canal, which connect the two ends of the bone, and in between these canals run the vessels as well as the nerves. So the same thing, the periosteal is the outermost layer, and it has a outer fibrous layer and inner cellular layer. In the cellular layer there are bone bone cellular cells, bone forming cells or cellular cells in there, and there then the compact bone, which consists of the osteocytes in the lacunae, and the endosteal layer as well. And the endosteal layer is just beneath the innermost. It's a lining between the inner cortical surface and the trabeculae, and it's about a 1 cell line thick, and it is composed of the bone lining cells, and usually these are inactive, and these prevent unwarranted bony resorption. And the bone matrix is usually it's formed out, it's a low content cell content and having non-cellular matrix, and there are usually two forms of the extracellular matrix, the osteoid and the mineralized matrix. And osteoid is immature matrix, and which is excreted by the osteoblast, and when it further matures with mineralization, then it becomes more dense, hence forming the mature matrix. And the bony matrix, it consists of the minerals in the form of calcium phosphate in the form of calcium hydroxyapatite, the proteins, mainly the collagens. Other proteins are also there, like osteonectin, osteocalcin, etc. Glycoproteins, proteoglycans, and even water can be present. And now we talk about the periosteal reaction. This is also known as the periostitis, and this is a very non-specific radiographic finding that occurs with irritation of the periosteum, that occurs with many pathological processes. And these reactions can be broadly can be categorized as benign or aggressive, and can also be further broken down by various patterns. Like the benign periosteal reaction can be because of very low grade chronic irritation that allows the formation of the normal or near normal cortex, but here the cortex will be thin, thick and dense, and can have a wavy or uniform appearance as well. Whereas in the benign periosteal reactions can even be seen in callus formation in fracture or with very slow growing tumors. Here we can see with a callus formation having a benign periosteal reaction in the form of solid periosteal reaction. And the aggressive form of the periosteal reaction, which occurs with a very rapid process, like very malignant processes, and even it can occur with infections like osteomyelitis, eosinophilic granuloma as well. And it is a very rapid irritative process that does not allow the periosteum to lay down and consolidate to form a new bone, normal cortex, and hence the cortex can appear as lamellated, amorphous, or even sunburst-like. And aggressive periosteal reactions can, as I have already said, can not only occur with malignant lesions, but can also occur in other benign processes like infections, eosinophilic granuloma as well. So here we can see very aggressive periosteal reactions, which is shown in this yellow arrow as well as the blue arrow. So morphologically, periosteal reactions are of 6 types. It can be single layered, it can be multi-layered, it can be solid, it can be spiculated with spiculations perpendicular to the cortex, or it can be divergent in the form of sunburst type. And this can be even disorganized or complex type, in which the reactions are very haphazard. They are not oriented to any direction, and Codman's triangle requires a special reference. A single periosteal reaction, as you can see here, it's a single periosteal reaction running along the cortex of the bone. It's a single layer of bone about 1 to 2 mm from the cortical surface, and usually seen in premature infants, can be seen up to 6 months. If there is a early fracture healing, or even in chronic venous insufficiency, it can be seen. The multi-layered kind of periosteal reaction, which is referred to as the lamellated or the onion peel kind of reaction, is seen usually in Ewing sarcoma, in which the periosteal reaction comes in concentric layers, as I have drawn here. The other is the solid periosteal reaction, which can evolve from a single layer or either multi-layered periosteal reactions. It forms a solid piece of bone or solid layer of bone just adjacent to the cortex. It can be seen even in this axial CT image. The speculated periosteal reaction can, as I have already said, it can either, this signifies a very rapid reparative process, underlying process that forms a new bone under the raised periosteum, and the orientation of the speculations or the spicules can reflect the direction of the tumor growth. And usually there are two types: the perpendicular type, the hair-on end type, or the sunburst type, divergent type. So these are the periosteal reaction. We can see the speculated periosteal reactions here. The same thing can be seen in here, and even in the CT images. And this is a very bizarre type of periosteal reaction, the sunburst type of periosteal reaction. Other one is the disorganized or complex type, in which the orientation of the speculations is very random and haphazard. As you can see, some are pointed towards one direction, some are in other direction. And a Codman's triangle, which is a distinctive kind of periosteal reaction, in which a distinctive triangular kind of periosteal reaction is formed, and this is referred to as a Codman's triangle, and usually it can be seen in various processes like osteosarcoma, and even in Ewing sarcoma can be seen. And these occurs when the lesion is very aggressive and it goes faster than the new periosteum can be laid down. And only the periosteum at the very margin of the lesion can be seen, because can be seen, which creates a kind of triangular lip as shown in the figure. So next we talk about bone infection or the osteomyelitis. Here the osteon and the myelo means, osteon means the bone and the myelo means the marrow. Itis, as we know, it stands for inflammation. So it consists of osteo meaning the bone, the marrow, and the inflammation, and it's an infection and inflammation of the bone as well as the bone marrow. And it can be sub-classified in various ways based on the organisms, based on its duration, acute or chronic, based on the root as well. And usually the etiology, this requires a special description, because commonly we are asked in entrance exam about the most common causative organism for osteomyelitis, and usually the Staph aureus is the most commonest in almost every age group. And in the this has been given according to age wise. So in the newborn group, usually the Staph aureus is the newborn, and even in the children and adults, Staph aureus is the main one. But the group A and B, Streptococcus and even Enterobacter can be other factors. In the susceptible groups like the injectable IV drug users, Staph aureus, even the Pseudomonas aeruginosa, Candida species can be etiological factors. In the immunocompromised group, the Staph aureus, other Bartonella and Aspergillus infection can also be there. In the urinary infection group, the Pseudomonas and Enterococcus group can be there. And other orthopedic fixation device, the coagulins negative staphylococci, and in the hospitalized patients, the gram-negative organisms can be also be a causative organism. So we can characterize osteomyelitis based on the duration, acute versus chronic. If it occurs in less than 6 weeks of duration, then it's acute. If it is present for more than 6 weeks, then it's chronic. And in acute osteomyelitis, other symptoms can also be present like fever, malaise, pain at the site of infection with limited range of motion, redness, warmth and swelling, which are all features of inflammation. And it requires aggressive antibiotic treatment more than even up to 6 weeks. Intravenous antibiotics. In chronic osteomyelitis, if it persists for more than 6 weeks, then usually it's common in adults who have recurring or chronic wound, and it can include other constitutional symptoms like low-grade fever, pain, draining sinus can also be present. And usually people who are immunocompromised, who are diabetic, can be at higher risk for chronic osteomyelitis as compared to other normal or non-diabetic patients. And this condition requires surgical debridement of the infected bone plus all the necrotic bones, and and the for appropriate targeted antibiotic therapy. The hallmark characteristics of osteomyelitis is destruction of the bone with the periosteal new bone formation, and usually the findings in radiograph, this has to be very clearly known. Usually the initial radiograph can be normal as long as up to 7 to 10 days, and usually the initial findings on osteomyelitis can be very subtle, and it can be just localized soft tissue swelling around the joint or around the adjacent to the metaphysis, because the metaphyseal end is the most commonest part that is involved in osteomyelitis, because osteomyelitis usually it's in the 2 to 10 years of age group, and there can be obliteration of the fat planes, which can be seen in after 3 to 10 days of the disease process, and the areas of bone destruction can lag 7 to 14 days behind the pathological process. And we talk about involucrum, sequestrum, and the cloaca formation. Involucrum is a piece of laminated or spiculated periosteal reaction. It's a new bone formation around the dead bone. Sequestrum is a piece of the necrotic bone which can develop after 30 days, and the cloaca formation is a defect in the involucrum, and it's a space in which the dead bone can reside. So the early findings, as I have already said, can only be a subtle soft tissue swelling, and there can be no any marked abnormality in the bone as seen here. We can just see some soft tissue swelling in the involved bone. Other features can be draining sinuses towards the skin surface, the formation of reactive bone formation of the involucrum, the piece of dead bone which is trapped inside in the form of sequestrum, and the periosteum with various periosteal reaction. So this shows the same thing. The piece of dead bone is usually sclerotic in the necrotic area, in the necrotic, and there is surrounding new bone formation, even sinus is coming out through the destroying the cortex. The same thing as shown here. This is the same thing, the osteomyelitic feature in the bone represented in the CT images, and this is the same thing in the MRI image, which shows various different levels of signal intensity changes in the metaphyseal end of the bone. This is the same thing that we have already discussed. So now we talk about the metabolic bone disease. So usually these are the disorders of the bone strength, and these can be caused by various disturbance in the minerals like calcium, phosphorus, magnesium, or even vitamin D. Out of which we discuss about these four are the most highly sought or the most important topics: the osteoporosis, osteomalacia, rickets, parathyroid disorders, and the scurvy. Osteoporosis is just it's a overall decrease in the density or the quantity of the bone. Osteomalacia and rickets is the qualitative defect in the bone. This is the quantitative one, and this is the qualitative one. These are the qualitative ones. And this can also occur with parathyroid disorders, with increase in the level of the parathyroid hormone or decrease in the level of parathyroid hormone, which can occur with with other pathological processes as well. And scurvy is a deficiency of vitamin C. So osteoporosis is a reduction in the bone mass that leads to increased risk of fracture, but here the ratio of the mineralized as well as the bone matrix, mineralized bone to the matrix is normal, and there is can be even imbalance in the remodeling of the bone. So this is a normal bone shown in the right image. This is the normal one, this is the normal one, and this is the abnormal one. So here we can see there is a definitive decrease in the density of the bone if you compare the two sides. The bone density in here looks okay, but here there is definitely decrease in the density of the bone with penciling with the wedging of the vertebra as shown here, and this can be this is due to osteoporotic wedging. So now we will be talking about the osteomalacia and rickets. As I have already said, these represent the qualitative deficiencies in the bone. So these are the qualitative deficiency in the bone. So osteomalacia and rickets, these are the same disease process or the pathological processes which occur in different age groups. Like if they occur in the immature bone or before the fusion of the growth plates, especially in the pediatric population, then they are referred to as the rickets. So these in the children or the pediatric population. And if it occurs in the adults after the fusion of the growth plates, then they are referred to as osteomalacia. And these in the rickets, there is deficient in mineralization of the bones, and there is less of non-mineralized osteoid in case of osteomyelitis, and both leads to the same radiographic features. And this can result from abnormality or deficiency of either there can be deficiency of vitamin D, calcium, phosphorus, alkaline phosphatase, or because of imbalance in the body pH. So the features are there can be growth plate widening, as can be seen here. The growth plate is widened in here. Even in this process, the growth plate is widened. The metaphysis flares out because of indistinct. The fraying means indistinct. Sorry, fraying means indistinct metaphyseal margin. Indistinct metaphyseal margin, and fraying is, it's like it frays out, it rocks out, the margin rocks out. So there is, and because the bones are softened, there can even occur bowing of the limbs or the bones, especially if once the child starts walking, and the legs can bow outwards, leading to variable deformities of the legs in the form of either coxa vara, valga, or genu valga or genu valgum. And the next thing is the hyperparathyroidism, which happens because of excessive parathyroid hormone in the body, and can be either primary deficiency in the parathyroid gland cell. It can be secondary to other stimulus like hypocalcemia, or even tertiary. An increase in the level of parathyroid hormone can lead to increase in osteoclastic activity, which results in increase in the bony resorption, and that can lead to cortical thinning and osteopenia, and hence the subperiosteal bony resorption is also the subperiosteal bony resorption is the hallmark of hyperparathyroidism, bony resorption. So the subperiosteal bony resorption, the Rogers spine, the osteopenia, we'll be talking about this in the upcoming slides. The brown tumors, terminal tuft erosions, which is also the result of the osteoclastic resorption of the bone. Even salt and pepper sign appearance, or the mottled appearance in the skull can be due to subperiosteal resorption of the skull bone. So there, because of subperiosteal resorption of the bone, usually it occurs in the radial side of the usually the second and the third digit in the middle phalanx. We can see the middle phalanx, the radial side is a bit, it's scalloping inwards, or it's with concavity inwards. So this is a subperiosteal bone resorption is pathognomic for hyperparathyroidism. Another can be brown tumors in the bones, which heal with when the primary insult is taken care of. And this is the Rogers spine, which is a pathognomic feature of this, and this can occur in renal osteodystrophy. One of the most commonest cause of secondary hyperparathyroidism that we have to remember is renal osteodystrophy. So they can even ask in exams like what are the features of radiological features of renal osteodystrophy or in patients of CKD. Then all these features, the features of hyperparathyroidism can inevitably occur in these patients as well. And this is the salt and pepper kind of appearance in the skull, which is a mottled appearance because of subperiosteal bony resorption in the skull. Scurvy is caused by a lack of vitamin C, and it does not occur usually before 6 months of age, because up to that age the maternal stores are quite sufficient to maintain the levels of the vitamin C. And since vitamin C, we have to remember one thing: vitamin C is not produced in a human. It's not produced in vivo. So hence it has to be taken in the diet, and it has to be supplemented in the diet. Hence a chronic dietary deficiency of vitamin D for about more than 3 to 6 months can result in vitamin D C deficiency. Hence it can occur in periods of chronic malnutrition, in periods of chronic other stress conditions as well. And vitamin C, it's important for collagen synthesis, and it's predominantly for the cross-linking of the collagen, of collagen. Hence, because of this, there will be the bones will be deformed, or there will be deficiency in the collagen polymerization will lead to compromise in not just in the bone, but even in the skin, the joints, and even the vascular integrity is compromised. And the general features in the in the scurvy are there is a generalized osteopenia in the bone. There will be thinned out cortex. The pencil thinned out cortex will be present, and this can be due to the periosteal reaction as well, and even because of subperiosteal hemorrhage. And these signs we have to be remembered for, because these are very important for the MCQs. There can be the Wimberger's ring sign, which is shown here, where there is a dense sclerotic epiphysis, small dense sclerotic epiphysis surrounding the epiphyseal centers of ossification, which can result from bleeding. And there will be Frankel's line, which is a dense zone of this dense zone of provisional calcification is referred to as the Frankel's line. And beyond this, just sub-adjacent to this zone, the radiolucent zone is referred to as the scorbutic zone, and just underneath that, and there can be even the Pelkin's spur or the fracture of this Pelkin spurs resulting in the Pelkin's fractures, which are metaphyseal fractures that results from the cupping of the metaphyseal ends, because these bones are eventually weak bones. So this scorbutic zone, the zone of provisional calcification, ring epiphyseal or Wimberger sign, these are important for MCQs in for the exams. So this is the same thing: the Wimberger ring sign, the scorbutic zone, and the white line of Frankel. The dense zone is the white line of Frankel, and this is the lucent zone is the scorbutic zone. And the fractures and dislocation, usually fracture it represents to any discontinuity in the soft tissues, and it does not always have to be a bone. But usually we usually talk about the any break in the continuity of the bone. And there can be injuries to joints as well in the form of subluxation or dislocation. If it is only partially displaced and there is some point of contact between the bone and the joint, then it's a subluxation or partial dislocation. It's not called not called dislocation, it's a subluxation. And if it is completely displaced without any point of contact between the bone and the joint, then it is referred to as dislocation. So here this is a schematic diagram representing the right hip joint, in which the head of the femur in the form of ball fits into the acetabular socket, and if it is having any point of contact with the socket, then it's referred to as a subluxation. But if there is no any point of contact between the socket and the femoral head, then it is referred to as dislocation. So the same thing here, you can see the fracture of the humerus in the neck of the humerus can be seen with, and here the shaft of humerus is fractured in the second image. This refers to the supracondylar fracture of the distal humerus, in which the distal humerus, there is fracture in the supracondylar region of the humerus, and with fat pad sign. So if they ask about fat pad sign, then we have to know that this refers to a supracondylar fracture of the humerus. And this is very common in the pediatric or the adolescent age group. And the next fracture is the Colles fracture, which occurs at the distal end of the radius at the corticocancellous junction with dorsal tilt, and this is also referred to as the dinner fork deformity, because the dorsal part is tilted backwards and it represents a kind of fork. So this is also referred to as the dinner fork deformity. Usually it's in people over 40 years of age, and usually particularly in women of post-menopausal osteoporosis. So here also we can see there is a fracture in the corticocancellous junction. And one thing we have to note is that this fracture in the corticocancellous junction, it should not extend to the intra-articular region for it to be called a Colles fracture. So if it does not extend to the intra-articular region, it should not extend into the intra-articular region, then it is referred to as the Colles fracture. The next thing in the scaphoid fracture, which is commonly in young adults, and it's one of the most commonest cause of osteonecrosis of the scaphoid. Usually it occurs in young adults, and it usually occurs through the waist portion of the scaphoid. So here we can see the lucent band throughout the waist of the scaphoid. This is the scaphoid fracture, and you can see even in the second image the scaphoid fracture. This image shows the pelvic fracture with in various parts of the superior and inferior pubic rami, as well as the eye leg region. And here there is pubic diastasis as well in the second image. Fractures around hip with can be seen in the neck of femur with break in the sentence line. This is the sentence line. This is the normal sentence line, as we can see, and there is breakage in the sentence line. And hence we can know that there is a fracture in the neck of femur. This is the intertrochanteric fracture of the right femur. The fractures around leg, ankle and foot can also be present. For example, there is a fracture in the distal tibia and shown here, as well as the distal fibular fracture. There is a fracture in the small lucent line running in the base of the fifth metatarsal. This is also referred to as a Jones fracture. So if somebody asks about Jones fracture, then we have to know that this is a fracture of the base of fifth metatarsal. So this is the same thing, and this is also the same thing. This is the lateral collis fracture. And other dislocations can also be there, like if they ask about like knee dislocation, then the posterior dislocation in the knee, in the hip is very common, whereas the anterior dislocation, this is for the knee, and for the hip, for the shoulder, anterior dislocation is more common in the shoulder. So this has to be taken care of. So here it shows the subluxation, in which there is a still contact between with the joint, hence it represents the subluxation. And here is total dislocation, in which there is the glenoid cavity is empty, or the glenoid fossa is empty, and there is anterior medial as well as inferior positioning of the humerus, head of humerus. So this is the dislocation. This is the same thing, the anterior dislocation of the elbow. This shows further dislocation of the left hip, and this represents the dislocation of the elbow joint. And we talk about even now the bone tumors. The bone tumors, usually these are classified as primary and secondary bone tumors, and usually the most commonest, this is frequently asked in the MCQs, like which is the commonest bone tumor. If they just ask about the commonest bone tumor, then the most commonest bone tumor is always the metastasis, or the secondary bone tumor is always the commonest one. And if they ask about primary bone tumors, then we talk about, if there is the benign primary bone tumor, then we talk about osteoid osteoma, and other malignant bone tumor, then osteosarcoma is the commonest malignant bone tumor, primary malignant bone tumor. Whereas if they ask just about the bone tumor, and even about the most commonest malignancy in the bone, then metastasis is always the commonest malignancy in the bone. So bone tumors are classified as either they are bone forming type, cartilage forming type, miscellaneous type, hematopoietic type, or fibrous type. So the bone forming type are osteoma, osteoid osteoma, osteoblastoma, osteosarcoma. The cartilage forming type can be chondroma, inchondroma, osteochondroma, or chondrosarcoma. Miscellaneous type can be Ewing's giant cell tumor. The osteoma is it's a benign tumor that is composed of sclerotic well-formed bone that is protruding from the cortical surface of the bone. Usually these are present in the paranasal sinuses. Here we can see the osteoma projecting from the frontal sinus. And these are osteoma present in the skull as well. Osteoid osteoma, this is the most commonest of the primary benign tumor. This is the most common primary benign tumor, osteoid osteoma. And there is a distinct nidus in this osteoid osteoma. This is the central portion is the nidus, and the whole of this is the osteoid osteoma. Osteosarcoma is a very highly malignant osteogenic sarcoma, or that is by the bone producing malignant mesenchymal tumor, and this has a very ill-defined, irregular, or the very aggressive pattern in the radiograph, in which the bony destruction is very aggressive. The periosteal reaction is also very haphazard and aggressive, as you can see, and there can be even extending into the surrounding soft tissue as well. This is the image given in the CT with aggressive bony destruction as seen. This is the case of Ewing sarcoma, which is a highly malignant tumor, and it's the second most commonest tumor, primary bone tumor in childhood. And usually the typical onion peel kind of appearance is seen here. And we have already discussed the lamellated or the cortical type of lamellated periosteal reaction is characteristic for the Ewing sarcoma, the onion peel type of reaction. It can even extend in this MRI. It's shown that it can extend throughout the it can extend throughout the diaphyseal end of the bone, with even the extension towards the extensive extension into the surrounding soft tissues as well. The next thing is the osteoclastoma, or commonly referred to as the giant cell tumor. So this occurs in those only with a closed growth plate, and usually this aborts the articular surface of the joint, like we can see in this case. This is a well-defined lytic lesion, expansile lesion, which aborts the articular surface, and it usually it extends from the metaphyseal end towards the epiphyseal end, and it's well defined with non-sclerotic margin, as we have seen. If it is usually eccentric, and if it is large, can be even difficult to access. And this is also a case of osteoclastoma, giant cell tumor. So thank you.